Dirk.
I have a very practical, simple question. That is, we do, in the Netherlands, we do also next generation sequencing and in many patients, but we have the possibility to give or to treat patients according to the mutation. That is, if you have a BRAF mutation in a non-small cell lung cancer patient, we can give them, say, a melanoma treatment. Oncomine, does it give you in your database also a display of the mutations, what you find, but also on not only lung cancer, but all mutations and all the, well, what is published or non-published on the potential targetable or drug available, if I express myself well?
Yes, it does. So you actually, this is the biggest problem that I have, that you have to put in the correct diagnosis into the database, and sometimes the people that help me signing out these cases put the wrong diagnosis, then I have to start uploading everything again. Yes, it takes into account the tumor type and refers to the tumor type. So if you find a mutation that is specific for other tumor type, it will say you this, and it will label it in a completely different way. So it will warn you that this is off-label use, and it will display it in a different column.
But you have the information.
Yes. Yeah. So I have to put it in. That's the reason why I always have to look at the tumor by myself.
Yes. Can you shout?
Yes.
Oh. Professor Mant.
Fascinating talks, particularly fascinated, of course, by clonal evolution, not only because it proves Darwin versus intelligent design, but because I think it shows what oncology is dealing as a problem also in common. Professor Corina, you mentioned Tim Lay's data, and I think you also showed some of Ben Everett's data from Hem-Onc, where we, since a couple of years, also find these sequences of mutation. Now we also find initiation events in otherwise healthy individuals that at a low frequency will indeed then also develop clonal aggressive hematologic disease. And I saw some analogy in your talk when you talked about these events that then are followed by events, let's say, in the upper pathway that lead to a higher qualitative drive. So the question is, would it be possible to detect, for example, by liquid biopsy, those early events and see whether at this phase you can already interfere with the development of the disease? This is the question we deal with in hematology, but I think it could be the same question also for lung cancer.
Sure.
How do you think of that in the future?
Yeah, just to bring others up to speed, there have been nice papers from St. Louis and a few other places now to show that healthy bone marrow of elderly patients harbor disease-causing pathogenic mutations. For example, DNMT3 mutations, even P53 mutations. And then some of them, upon exposure to cytotoxic therapy, go on to develop therapy-related acute myeloid leukemia. You know, when patients get etoposide after 5 years, 10 years, you get acute myeloid leukemia in a small number. It turns out that the archival bone marrow done for something else showed that these patients had one pathogenic mutations. So what our good friend Tim Lay calls soft kiss of death. And you have one alteration that has happened, maybe you have another alteration, or a third one eventually pushes down the path. So it's entirely possible that if we do sophisticated blood or mutation analysis in the blood, we may have a lot of mutations in our bloodstream, and many of them may not go on to cause disease. Only a few of them in some patients would do it, partly because it may depend on the acquisition of other alterations. So this actually takes this screening to an entirely different complexity. You know, you talk about false positive on CT screening. Here we have no idea what the trajectory is. I suspect that in a future day there will be an archival sample analysis done in all these population-based samples, and we may figure out a subset of patients who would need close monitoring or some kind of a therapy to avoid the evolution of this, for example, targeting upper back. And I can see all these things happen. One thing, people can comment on this, that right now in plasma, looking for for solid tumors, very few people have done the whole exome sequencing in the peripheral blood. In fact, we are trying to do whole exome, even transcriptome sequencing in the peripheral blood of the tumor DNA. But it gets very expensive because the coverage is very low, and you got to sequence, you have to have a very high level of coverage. So there are technological challenges that we will overcome. The short answer to your question is that I think with emerging technology, we'll be able to do the analysis of the tumor DNA, RNA even perhaps, in the blood over the next 5-10 years at a much more higher level, broader scale, and deeper level. But what we can do with that information, I think, is going to be very challenging. It'll take many years of screening studies to really understand what they all mean. Sometimes it's good to not to know certain things, and this may be one of those things, but I think we need to address that over time.
I have a question to you. I mean, now this maturing of PD-L1 expression in the archival material is such a strange thing. And I have this patient with a dramatic response, and you reported no PD-L1 expression, so I want you to go back and do it there again. So I don't know, have other people observed this, or is that your observation, the maturing in archival tissue?
Well, that's a difficult issue, but let's say the reproducibility of IHC, I mean, here we are talking about percentages of cells, so we are talking about 10 or 50% of the cells. It's clearly so that depends, for example, on what is always not really recognized is that you have batches of antibodies. So, of course, you obtain every 3 months a new batch of antibody, and that's another batch, another lot that you buy from the company. So it can well be that the next batch is a little bit stronger or weaker than the previous. I mean, that's, for example, even if you keep all the parameters on the machine the very same, these are different antibody batches, for example.
And I have a short question to Peter. So your fast track results, is it for technical reason that the HER2 mutation is not there, or just you had to make a selection of most important mutations?
No, the selection wasn't done by us, but by the provider.
Okay.
So there is much more stuff coming in the future, but this is only the cartridges that are available.
Okay.
So.
Good. I see no other questions. I think we are right